When we look at innovation, new product, new solution, we want to always improve outcomes. Clearly, it's benefit for patients, right? And put patients at the heart of what we do. And we discussed earlier about how patients should be more involved in their care to ensure that the journey is much better and also to improve their quality experience and outcomes. But by the same token, bring a new device onto the market or new ideas, there's always concern about safety. As a surgeon, we know we have complications, we do things that sometimes are harmful, and actually, what about safety going forward? AI is, of course, very big, and this whole session is around AI over the last, since this morning, of course. And you saw Rishi Sunak, of course, in the government, run the AI Safety Week a few weeks ago in the UK, the first such get-together of minds around the world to understand where AI might be heading towards, its risks and benefits, and how we should manage it in terms of the risks as a society. Healthcare is very much part of that. We need to have those conversations as we go forward now around that. So who better than to talk about patient safety than the Patient Safety Commissioner? And so I met her for the first time really yesterday, for the first time. And Dr. Henrietta Hughes does an amazing job and would at least help us make sure whatever we do has impact for patients, but puts their safety at the forefront of our minds, and of course for them. Henrietta.
Well, thank you so much for inviting me. It's a real pleasure to be here. And I want to talk about some of the opportunities, but also what I see as some of the risks and how we can mitigate those in the use of AI as a medical device. So my role is the first Patient Safety Commissioner in the world, so you have to forgive me because I'm learning by doing. My background is as a GP, and so I'm particularly interested in the priorities that I have, which are around focusing on promoting patient safety and on promoting the views and voices of patients and how we integrate those into the design and delivery of healthcare so that we can keep our patients safe. My role came from a report called First Do No Harm by Baroness Cumberledge, where she heard from people who'd been harmed through the use of medicines and medical devices, where they hadn't received the information they needed to consent to their care. And when they did raise concerns, they weren't listened to, and those concerns weren't acted upon. Baroness Cumberledge described the health system as slow, siloed, and lacking in compassion. And I think we together, as leaders, are able to change that so that we can incorporate the views and voices of our patients, so we can adapt technologies to make them safe. So when I think about the use of AI, I want to talk a little bit about the way that it's being used already in terms of some of the regulation and the impact in terms of professional regulation as well, because we'll need to be thinking about what it means to us or those of us in the room who are healthcare professionals in the way that we work now and in the future. And the best way to adopt new technologies is to make them safe. And we need to develop the expertise and know how to marshal it as well. Because at one end of the spectrum, we've got the benefits to patients, but at the other, we have the existential threats, such as an AI tool designed to develop new medicines could also be used to develop bioterrorism. There are also immediate risks in terms of disruption to jobs, but I see it that with 110,000 vacancies across the NHS, there are real opportunities to reduce the bureaucracy, so it releases time to care, and that means that we can provide more compassionate care for our patients. So as a GP, I'm not yet using AI to do the medical records, but my colleagues are, and they're saying that it's really transforming the time that they spend with patients, that the AI is listening into the consultation and then produces some really excellent clinical records at the end of it. But it's even more than that. In one hospital in London, the AI is not only making the medical record, it also follows the NICE guidance and it's ordering the tests. And I think this is really transformational in terms of delivering really high quality evidence-based care. There's also something about consent. As I mentioned in the Cumberledge review, the patients didn't get the information to be able to consent to their treatment. But are we satisfied just to give the European average or even the average for this country? Wouldn't we like to have personalised consent so that we know that individual surgeon or that individual patient? And at Great Ormond Street, they've developed an AI tool to give personalised consent for patients who've got complex multimorbidities so that they're really able to engage in their own treatment and understand the potential benefits and risks, not just for patients in general, but for themselves in particular. But one of the things I would say is that we can use AI for the recognition of rare but complicated diseases such as childhood cancers and sarcomas. But there is also something around the advantage we have in the UK because we have the NHS number as a unique identifier. And it means that we're able to then scan multiple records so that we can understand not only what is causing a problem for patients now, but perhaps what happened to them in the last few years so that we can use it as a predictor. And that then comes on to security and privacy. If we are scanning huge amounts of patient data, it might know more about us than we know about ourselves or care to know about us. For example, AI that can diagnose Parkinson's by the sound of your voice. And some people don't want to know, and we have to be really mindful about the individual patient and what it is that they are happy to tolerate in terms of having information which might not only impact on themselves, but on their family as well. But also, who else holds that information? And with the federated data platform that's recently been announced, I know that there are some people who have real concerns about data and where that data is going to be held and who is going to have access to it. So have we considered what this means about privacy and about consent? So as artificial intelligence and machine learning, we're able to look at the operational risk, we'll look at the hazards, and managers will have more tools at their disposal to be able to make better decisions, but they must take time to become familiar with the technology, the products, what the tools can do and what they can't do. We also need to think about the security of the systems. If we're relying on technology, we need to be prepared for cyber attacks. We know what's happened recently with the NHS not being targeted through WannaCry. It was more to do with the estate being in a terrible situation. But also with Advanced recently, we know that there are real risks to patient care. If we've got people having to resort to paper records during a cyber attack, how are we measuring the harm and how are we using duty of candor to be able to share that back to our patients? It really does sound fantastic that AI can listen into the conversation and it can make the medical records. But think about it in the other sense. Would you be satisfied if you put a complaint into a trust for ChatGPT to write your response? Are we able to contract empathy out to a chatbot? So I asked myself, what does this mean about control? What do we do if the technology fails? We need a human fail-safe mode in all of this, because in a high-pressure situation, would you follow the sat-nav off the edge of a cliff? And we need to think about safety balanced with outcomes and how we bring the patient voice into this as well. Because in aeroplanes, autopilots are exceptionally safe during takeoff and landing, but we still have a pilot there behind the joystick, not only because, if the system fails, but also we don't want to de-skill the experts so that they're able to take over if the technology fails. And this brings me on to trust. The most widely adopted techs are the tech which is trusted, and this is about storytelling and context. I mentioned before about the federated data platform. This is something where we have to engage the trust of the patients and the public and the professionals who are looking after them. There might be things that AI is able to deliver that humans can't, but we do need to have a better understanding of how it works and how it's come to this decision. Because I asked myself, who carries the liability if the AI is incorrect? Is it the software developer, the NHS, or the individual clinician? And AI isn't always correct. We know that sometimes it can come up with rather inconsistent and unreliable data. And what I think is really important is for the clinicians in the room, the Bolam test, which is the test about, are you doing what a body of other doctors is doing? It doesn't apply if only a few people are adopting this technology. It's going to take a while for this to become rolled out and business as usual. The next question I ask is, if a patient accesses information from their wearable, I heard an anecdote of a patient saying, according to my watch, I'm dead. The fact of the matter is, we have to say, as doctors and healthcare professionals, what is our responsibility to act on that information? As a GP, I got a lot of patients who are having online tests that they're ordering themselves, self-testing, and then they come with a group of results and say, doctor, can you analyze this? And I say, no, take it back to the person who ordered them. That's the way it works. But there is something about giving patients more autonomy and having that shared decision-making. We've also got to be prepared for the next step, which is that people are accessing information for themselves and following up on it. And previous history shows that we're much more likely to believe the machine than the person. And if you think about, for example, the post office scandal and others, where the computer has said one thing and we all believe it. There was a situation where I think 70 nurses were disciplined in one organisation because it looked as if they'd put the incorrect information into a device on the same day. And in fact, what had happened was somebody from the company had come and made a change to the software. And clearly the problem was with the machine and not with the professionals. So the next thing I was going to say is that algorithms are really smart, but it might not be the answers for the reasons that we're expecting. So you've probably all heard this before, but AI is really good about distinguishing between a wolf and a dog. And we think, gosh, how clever is that? But is it because of the animal themselves, or is it because in pictures of wolves there's usually snow in the background and dogs are normally wearing a collar? And that brings me on to bias. One of the great advantages I think that we have in terms of AI is that we can remove some of the bias that exists in the system already. But there are risks around bias that can come from information which is sitting in the system that AI is using to make a decision. So if I take, for example, medical devices, women tend to do worse in terms of heart valves. And the reason is that heart valves have been designed for men. But if we take 10,000 CT scans of women's hearts, we're able to then design in the virtual space devices which are of the right size so that women will get better outcomes. Also, when it comes to other medical devices, we know that there are biases that exist, for example, in terms of the green light that is used in pulse oximetry and in dermatoscopy. One of the things which is really important about this is that we need to express the results of research by personal demographics. Then we understand where the bias is. If I give you an example from insurance, when AI was used to determine payouts from insurance claims, the machine gave lower payouts to people from minority groups. So then coming on to regulation. Regulation will often lag new technologies, and we need to ensure that AI in healthcare is safe. We need to learn from other areas where patients have been harmed by the use of devices. So going back to the Cumberledge Review, let's start with the perspective that we need to be prepared that something is going to go wrong. And we need early signal detection and swift action. We need to include the voices and views of patients and families and service users, along with software developers and clinicians, so that when we design these services, we know that they're going to work in the real world. Because all too often in healthcare, we let the hazardous event occur and then we look for mitigations and ways of managing that. But if we can use the lessons learned from the Cumberledge Review and others, we can ensure that when new devices, AI included, are brought into practice, we can identify the hazardous events that we're trying to avoid and put the controls and measures in place. In this way, we'll not only derive the benefit from AI, but ensure that we keep everyone safe as a result. Now, clearly, when I was thinking about doing a talk on AI, I thought to myself, I need some support here. So ChatGPT wrote half of this talk. I'm not going to tell you which half, but I hope that you'll enjoy using the devices, but also think about the views and voices of your patients and service users when you're bringing new systems into place. Thank you very much.